Without further ado, we're going to start on the discussion on beta-lactam antibiotics. To start, what are beta-lactam antibiotics? These antibiotics have a beta-lactam ring as the essential antibacterial component in their chemical structure. The antibiotics under this group consists of penicillins, cephalosporins, cefamycins, monobactams, and carbapenems. One of the beta-lactam drugs are the penicillins. Penicillin was originally discovered by Sir Alexander Fleming in the filtrate of culture medium of mold Penicillium notatum, having bactericidal action on Staphylococci in 1929. Penicillium chrysogenum, a mutant of Penicillium notatum, is presently used for commercial production of antibiotic. Penicillin was the first antibiotic to be used clinically in 1941, signaling commencement of the golden era in chemotherapy. The chemistry of penicillin. The basic structure of penicillin comprises of the thiazolidine ring T connected to a beta-lactam ring B, to which a side chain R is attached through an amide linkage. The bacteria which elaborate the enzyme penicillinase, a beta-lactamase, are resistant to penicillins. The enzyme breaks the beta-lactam ring Bl and inactivates penicillin through formation of penicilloic acid, which does not possess antibacterial activity. Benzylpenicillin has a narrow spectrum activity, effective against gram-positive organisms, especially against cocci but not against gram-negative organisms, except a few. In general, viruses, fungi, rickettsia, chlamydia, acid-fast bacilli, and majority of gram-negative bacteria are insensitive to penicillin G. It is bactericidal at 0.5 units per ml concentration. Its action is unaltered by blood, pus, or tissue breakdown products. The extended spectrum penicillins are active against gram-positive and gram-negative organisms. Penicillins are classified into various groups based on their source. The natural penicillin is known as benzylpenicillin or penicillin G, and it is thermolyable and acid-liable. Penicillin salts are formed by replacing hydrogen with sodium and potassium from the carboxyl group attached to the thiazolidine ring. These salts are highly soluble and more stable than the parent acid. They are stable in dry state but deteriorate rapidly at room temperature. Therefore, penicillin G solutions are always prepared freshly. Soluble sodium or potassium salts of benzylpenicillin or penicillin G destroyed by gastric acid, orally inactive, and penicillinase given intravenous, intramuscular, or subcutaneous, onset of action within half an hour and duration of action only 3 hours. Sparingly soluble organic salts of penicillin G or repositories penicillins are procaine penicillin G, administered intramuscular, never intravenous, onset of action within 6 to 8 hours, destroyed by gastric acid and by penicillinase, and duration of action 12 to 24 hours. Incidence of hypersensitivity reaction is most common. Next is we have the benzathine penicillin G. It is administered intramuscularly and never intravenously, and the onset of action is slow. The duration of this drug is 1 week. While the semi-synthetic penicillins have been developed by adding different side chains to it with unique antibacterial activity and variable pharmacokinetic properties. First, for our semi-synthetic penicillin are the acid-resistant penicillins. First, we have the phenoxymethylpenicillin or the penicillin V. Second is we have the phenoxyethylpenicillin or the phenethicillin. Second, we have the penicillinase-resistant penicillins. First is we have the acid-liable penicillins, the methicillin and the naficillin. Second is we have the acid-resistant penicillins, the flucoxylin, osaxilin, closaxilin, and diclosaxilin. Third is we have the extended spectrum penicillins. These are not penicillinase resistant. These are the aminopenicillins, effective against gram-positive and gram-negative bacteria. These are the ampicillin, vancomycin, talampicillin, pivampicillin, and amoxicillin. Here we have the example, amoxicillin. Second, for the extended spectrum penicillins, these are the carboxypenicillins. These are active against Pseudomonas aeruginosa and Proteus species but not ineffective against Klebsiella and gram-positive cocci, carbenicillin, and ticarcillin. Third, for the extended spectrum penicillins, we have the iridopenicillins. These are active against Pseudomonas and Klebsiella species. Examples are the meslozillin and the piperazillin. The fourth and the last extended spectrum penicillins are the amibinopenicillins. Examples are mesillinum and the pivemicillinum. These are highly active against gram-negative bacilli, except B. All the other penicillins are resistant to penicillinase. Moving on to the mechanism of action of penicillin, the gram-positive bacterial cell wall comprised of peptidoglycan having linear strands of two alternating amino sugars, N-acetylglucosamine and N-acetylmuramic acid, which are cross-linked by peptide chains and give rigid mechanical stability to the cell wall. Penicillin blocks the cell wall synthesis by inhibiting transpeptidase enzyme and other proteins, penicillin-binding proteins PBP, that cross-link the peptide chains of the sugar residues. The final bactericidal effect is due to the inactivation of an inhibitor of the autolytic enzyme in the bacterial cell wall. Penicillin G, its salts, and methicillin are destroyed by gastric acid and are orally ineffective. Only the acid-resistant penicillins like ampicillin can be given orally, and their peak plasma concentration is reached within about 2 hours. Most of the penicillins, including repository penicillins, are administered parenterally, usually intramuscular. Penicillins are widely distributed in the body fluids and tissues. They can cross the blood-brain barrier or BBB in the subtherapeutic concentration in the presence of inflammation of meninges only. Penicillins are chiefly excreted through kidney, 90%, and changed in urine, out of which 20% is by glomerular filtration and 80% by proximal tubular secretion. Some broad spectrum of semisynthetic penicillins are also excreted through the bile. So what are the clinical uses of penicillins? First, we have the treatment of local and systemic infections caused by the sensitive bacteria. Penicillin G is of the value in the treatment of bovine mastitis, primarily in the streptococcal mastitis, anthrax, erysipelotrix infection in sheep, pigs and birds, strangles in horse, clostridial infections, tetanus and black quarter, pyelonephritis and lumpy jaw in cattle, beta hemolytic streptococcal infection in puppies, in meningococcal meningitis, and in leptospirosis. Next, in this slide, we have the administration and dosages of penicillins. The dosage of penicillin is usually expressed as units. 1 unit of penicillin is defined as the amount of antibacterial activity present in 0.6 microgram of pure crystalline standard sodium penicillin. The dosage of semi-synthetic penicillin is expressed in milligrams per kilogram. In this table, it highlights the administration and dosage of the different kinds of penicillins, such as the benzathine penicillin G, penicillin V, sodium penicillin G, and procaine penicillin G. The continuation for the administration and dosage of the penicillins are the highlight on this table. These are the ampicillin, amoxicillin, carbenicillin, fluoxacillin. Furthermore, in the treatment of bovine mastitis caused by Streptococcus agalactiae, penicillin G is administered systematically or by intramammary fusion at 300,000 units per quarter thrice a day. Next, in this slide, we have the withdrawal periods or WP following penicillin therapy. This table highlights the withdrawal periods of the following: prasine penicillin, benzathine penicillin, amoxicillin intramuscularly, ampicillin intramuscularly. Benzathine penicillin G and procaine penicillin G in oil. These are penicillins which are slowly absorbed over a period of 5 to 7 days following a single intramuscular injection. Probenecid delays renal excretion of penicillins and prolongs the blood vessels of penicillins with short plasma half-life. It is added at 1 to 2 milligrams per 1,000 IU of penicillin G for oral dosing in dog at 6-hour intervals. The repository forms of penicillin should never be injected intravenously. Now we move on to the adverse reactions and toxicity of penicillin. Hypersensitive, allergic, or anaphylactic reactions, mostly along with streptomycin, are reported in dog, cattle, and horse following prior sensitization to the antibiotic. The clinical signs noted were salivation, shivering, vomition, and urticaria in cat and dogs, labored breathing, salivation, cutaneous edema, and froth from nostrils and mouth in cattle, and urticaria and pruritus in horse. Overall, penicillin toxicity is uncommon in animals. Next, we move on to the beta-lactamases. Beta-lactamases are enzymes produced by penicillin-resistant bacteria, which break the antibiotic into inactive penicilloic acid. They are named as beta-lactamases as they act by splitting the beta-lactam ring, present in beta-lactam antibiotics, penicillins, and cephalosporins. The enzymes are the two types, the penicillinase and the cephalosporinase. In this next slide, we have the beta-lactamase inhibitors. These potentiate or re-establish the antibacterial potency of penicillinase, sensitive penicillins against beta-lactamase producing organism by inhibition of the enzyme. These inhibitors are structurally similar to penicillin and act as substitutes for penicillinase, causing inhibition of the enzyme. There are three classifications of beta-lactamase inhibitor. These are the clavulcanic acid, sulbactam, and tazbactam. First is we have the clavulcanic acid obtained from Streptomyces clavulingerus and has no antibacterial activity of its own. It is generally combined with amoxicillin or ticarcillin. Second is we have the sulbactam. This is a semi-synthetic beta-lactamase inhibitor related chemically and in activity to clavulcanic acid. It is combined with ampicillin and preferably for oral and parenteral administration. Lastly, we have the tazobactam. It is similar to sulbactam and combined with piperacillin. In this next slide, we have the potentiated penicillins. The penicillins in combination with beta-lactamase inhibitors are called as potentiated penicillins. The combinations are clavulanic acid amoxicillin 2:1 ratio, clavulanic acid ticarcillin 15:1 ratio, and sulbactam ampicillin. The dose of these potentiated penicillins are for potassium clavulinate and amoxicillin 1:4 ratio at 10 to 20 milligrams per kilogram amoxicillin, and 2.5 to 5 milligrams per kilograms clavulinate orally at 12 hours. Note that penicillins with sulbactam and tazobactam are administered intravenously, whereas those with clavulanic acid are administered orally or intravenously. Moving on, we have the cephalosporins. These are semi-synthetic antibiotics obtained by making different substitutions in 7-amino-cephalosporanic acid of cephalosporin C, produced by mold belonging to Cephalosporium or Cephalosporium acrimonium. Moving on to the next slide, we have the classifications of cephalosporins. This classification is based on the route of administration. First, we have the first generation. In the first generation drugs of cephalosporins, these are the oral route of administration. The cephalexin, cephradine, cephradroxil, and cephaloglycine. For the first generation parenteral drugs, we have the cefapirine, cefazolin, cefalothine, and cephalonium. And for the intramammary route of administration for the first generation of cephalosporins, we have the cefacitril, cefapirine, and cephalonium. Moving on to the second generation, for the oral route, we have the cefaclor, and for the parenteral route, we have the cefamandole, cefonicid, ceforonide, cefotoxifin, and lastly, we have the cefuroxime. For the intramammary route, we have the cefuroxime. For the third generation under cephalosporins, the oral drug is the cefixime, and the parenteral drugs are the cefamenoxine, ceftiofor, cefoperazone, cefotaxime, cefsulodine, ceftazidime, ceftizoxime, ceftriaxone, ceftibuten. Lastly, for the fourth generation of cephalosporins, there are only parenteral drugs, which are the cefepime and cefpirome. Moving on to the chemistry of the cephalosporins, the cephalosporin molecule contains a 7-amino cephalosporanic acid consisting of a beta-lactam ring like penicillins and dihydrothiazine DT unlike penicillins. Unlike the 6-amino penicillinic acid of penicillins, the 7-amino cephalosporanic acid molecule and cephalosporins provides more sites for chemical manipulation in the production of many semisynthetic cephalosporins. Shown in this slide is the chemical structure of the cephalosporin or the 7-amino cephalosporanic acid. Now we move on to the antibacterial spectrum of cephalosporins. To start, here is the first generation. Cephalosporins have high activity against gram-positive but are only with moderate to weaker activity against gram-negative organisms, relatively susceptible to cephalosporinase and are not effective against anaerobes. Moving on to the second generations, cephalosporins are more active against gram-negative and gram-positive organisms and are relatively resistant to beta-lactamase. In the third generation of cephalosporins, they are more effective against Enterobacteriaceae and much less active against gram-positive, and some cephalosporins have good activity against Pseudomonas aeruginosa and are very much resistant to beta-lactamases of gram-negative bacteria. Most of them can penetrate blood-brain barrier and frequently indicated in bacterial meningitis. Lastly, in the fourth generation of cephalosporins, they have activity comparable to third generation but highly resistant to some beta-lactamases. Cross-resistance is less among bacteria to penicillins and cephalosporins. The cephalosporins are ineffective against cephalosporinase producing bacteria. The cephalosporinase splits the antibiotic into microbially inactive cephalosporanic acid. The enzyme also attacks penicillin. Now, we move on to the mechanism of action of cephalosporins. Cephalosporins interfere with the bacterial cell formation by interfering with the transpeptidation by inhibiting transpeptidases similar to penicillins. Now, moving on to the clinical uses of cephalosporins, first-generation cephalosporins are used as alternatives to penicillin G in staphylococcal infection and for surgical prophylaxis. Ceftiofor is specifically used in bovine bronchopneumonia caused by P. multicoda or P. hemolytica and in urinary tract infections in dogs. Cephalosporins are useful in treating infections of soft tissues and bones, meningitis, osteomyelitis, prostatitis, arthritis, and urinary tract infection. Cefapirine, benzathine, and cefapirine sodium are used in the treatment of mastitis. Now, let's learn the administration and dosage of cephalosporins. For oral cephalosporins, for dogs, cephalexin at 15 mg per kilogram twice a day, cefadroxil at 11 to 22 mg per kilogram once or twice a day, and the other cephalosporins are administered in dog and cats at 10 to 20 mg per kilogram at 8 to 12 hour intervals. For calves, cefadroxil at 35 mg per kilogram, cefaclor at 3.5 mg per kilogram, and cefradin at 7 mg per kilogram at all 12-hour intervals. For the parenteral cephalosporins, the cephalotin for dogs is 20 to 40 mg per kilogram intravenous at 6 to 8 hour intervals. Cefazolin for dogs, 15 to 30 mg per kilogram intravenously at 12-hour intervals, and for horse, 15 to 20 mg per kilogram intravenous at 12-hour intervals. While the cefotaxime for dogs is 20 to 40 mg per kilogram intramuscularly at 8-hour intervals, or 50 to milligrams per kilogram subcutaneous at 12-hour intervals, and for goats, 50 milligrams per kilogram intramuscularly at 12-hour intervals, and for horses, at 20 milligrams per kilogram intramuscularly at 8-hour intervals. And for the cefoperazone for dog and cattle, 30 milligrams per kilogram intramuscularly at 6 to 8-hour intervals, and the ceftazidime for cattle, 20 to 40 milligrams per kilogram intramuscularly at 12 to 24-hour intervals, and for the ceftufor for cattle, 1.1 milligrams per kilogram intramuscularly once a day. Note that in the treatment of bovine mastitis, the intramammary cephalosporin infusion preparation used are cefoperazone, cefalonium, cefuroxime, cefacitril, and cefapirine at 250 mg per quarter. Cefoxazole at 250 mg along with 250 mg of procaine penicillin G is also available. Now we know about the dosage and administration of cephalosporins. Now we move on to the side effects and toxicity of cephalosporins. Cephalosporins are relatively non-toxic, although some are nephrotoxic. Intramuscular injection is painful, and injection outside the vein may cause thrombophlebitis, hypersensitivity, superinfection with Pseudomonas or Candida. Some cephalosporins, cefoperazone, ceftriaxone, and moxilactam cause warfarin-like hypoprothrombemia, causing prolongation of clotting time and bleeding. Moving on, we have the cefamycins. These are closely related to cephalosporins but have a methoxyl group at position 7 of beta-lactam ring of 7-amino cephalosporanic acid nucleus. Cefamycins are also produced by streptomyces. The common cefamycins are cefmetazole and cefotetan, which are similar in properties to second-generation cephalosporin. Moxilactam, a synthetic cefamycin, is similar in action to third-generation cephalosporins.